Good morning, and thank you for joining us. We have a few joining us online this morning, so we welcome you and thank you so much for being part of this morning's session, which is part of our lifelong network for communities of support. It's a parent coaching group that we created over the last few years and launched late last year, and this is our fifth session. We have explored things from community development to legal concerns and wills to finance. And today we're thrilled to have Dr. Javier Cardenas joining us to talk about health and wellness, as we know that's a huge priority, number one priority for us all. So as we go through this morning's presentation, we want to talk about the readiness questionnaire briefly. Many of you who have joined us in the past have already completed such a questionnaire, and it's really focusing on, are we ready for those next big steps as we think about making sure our loved ones are ready. We'll go through a brief community building exercise as part of our continued efforts and part of every session. And we want to give you a few updates on what's happening with First Place Phoenix 2. And then we're going to turn it over to the expert, Dr. Cardenas, and then come back together for questions and answers. And for those of you online, you can also be submitting your questions and answers too. Well, this is First Place. It is actively under construction. Actually, that stucco that you see is being applied, so it is becoming a reality. And as much as we are a real estate developer, we are a community developer. And it's about opening doors to more options in lots of different places. Certainly the real estate and where people live, where they work, where they worship, where they recreate, where they find their friends, and what we know to be a very supportive community. And our vision is to ensure that options are as bountiful for people with autism and other abilities as they are for everyone else. And that includes so many of us and our loved ones and people we care about the most. We know that from our focus groups and the nearly 2 decades of research that at the heart of it, as family members, we want our sons and daughters and family members to be happy. And right after that, if you go to the bottom, it's we want them to be healthy. We want to know and make sure that somebody knows their story when we're not there with them. We also know that families are very concerned about finance. So unlike senior housing later in someone's life, we're talking about the beginning of someone's adult life. And First Place is really being designed to ensure that we can front load early education, independent living skills, and more, increase their quality of life, their level of independence, and over time reduce the cost reduce the cost of care. We also know families want to stay in touch with individuals after they leave the family home. So that's why communications and technology is so important, and why First Place has been working with 2 technology planners from Intel over the past few years. We also know that families want their sons and daughters to get out of their rooms. It's not just enough to have a room, but being able to be part of a supportive community, which gets us to the answer for that looming question of who's going to care for them when we're no longer able to do so. And the answer is community. More eyes and ears create more opportunities and more safety and security. And so First Place includes these 3 uses. We have a transition academy for student participants, supportive housing or apartments for residents, and then our Global Leadership Institute. And before we take off this morning, I just want to remind you of what that represents. We have 55 studio 1 and 2 bedroom units, and Sarah Hetrick, who's joined us this morning, is our Director of Community Life and Support Services, and she is actively underway on leasing activities. So if any of you are interested, there's a whole lot of information online under the apartment tab. We're also working on a very robust community life featuring our firsties, which are the first early adopters, First to the Table culinary instructional program, a First Place First Time program. And we had a very exciting meeting just last week with 12 leaders of our arts and culture organizations, ranging from theater to and performing arts to museums to the Desert Botanical Gardens, and opportunities to open doors for individuals to experience this arts and culture community that we marvel at through introductory memberships, through complimentary tickets, and really learning what you do in a theater. We call it Meet Your Seat kind of educational program, and being part of rehearsals so that they truly appreciate what goes into a performance. We also are working closely with a resident advisory council to continue to inform our plans, and we do anticipate lots of celebrations of firsts after first place is opened. The Transition Academy is now underway. It's been operating for 3 years in what we call a beta site property, which co-locates students with autism with seniors who do not have autism. And it's a beautiful expression of community. Starting this summer, our freshmen will be living at First Place Phoenix, the new property. And this property, which will allow for greater independence, will be for second-year students. And enrollment is underway. We have a few slots that remain for the 2018 class, and are excited about what these participants have been experiencing through their community engagement, through 32 semester-length courses in life skills and career readiness and interpersonal skills, and through employment opportunities. Everything from getting ready and getting there, which includes transportation, to working as a team, to managing expectations, to communicating with an employer, and to what to do with a paycheck. So this is a program now underway, and the results are very encouraging. And our sophomores will be graduating with the class at Gateway Community College this summer, and walking with that class. And many of our students are now working on their transition plans, and also identifying their roommates, some of the very friends that they made during the program. And finally, we have our First Place Global Leadership Institute. And this is a space where we will be continuing to do more education, training, and help with that employment. As a matter of fact, we have a job and workforce initiative underway with other collaborating organizations, including the Southwest Autism Research and Resource Center. And our goal is 1,000 jobs for people with autism and other disabilities and different abilities by 2025. Got to get that out, 2025. And we're working on it. We were just with an IT company this last week that is looking at a site in Phoenix, and it looks very promising. We're also advancing plans for our Real Estate and Community Development Center, and we are hosting a symposium April 25th through 27th through that Real Estate Community Development Center, and that's really an opportunity to help share what this community has been doing with others who have an interest from across the country and actually around the world. We have also a center with applied research, one for expression, and finally for public policy, as we want to ensure that more options for more people are developed through the years. And we know we need public, private, charitable, and nonprofit collaboration to get there. So in a nutshell, that is First Place. We broke ground at the end of 2016 and will be opening this summer. Actually, our first residents will be moving in July 1, which is a Sunday. And we are hosting a collection of hard hat tours. Our next one is coming up next Saturday. If you want to meet us at the site at 10 a.m., we would love to share what's happening inside First Place, and then also treat you to a ride on the light rail, where we will hang out at, where we'll go downtown and hang out at the bowling alley, Lucky Strike, and you can enjoy some pizza with us too. It's a great opportunity to make some friends, and we have a few emerging bowlers in the group here this morning that have come back. So please join us. It's all about making friends, getting to know not only the fellow residents, but also families getting to know each other. And it's a great expression, again, of community. So you too can wear a hard hat and a colorful vest like this if you join us next Saturday, which is the 24th at 10 a.m. at the site. So we truly believe this is history in the making. New, innovative, different type of housing to accommodate for the 500,000 children with autism now transitioning to adulthood this decade, and so many others. And you also saw earlier with our beta site this opportunity to create other affordable housing opportunities. And I'm thrilled to share with you that the Arizona Department of Housing approved another grant, which is going to make another 29 Palms property possible in collaboration with the Foundation for Senior Living. This new property will be at 20 Missouri and about 21st Avenue, so also with easy walk to the light rail. And so we're excited about what's emerging here in terms of more opportunities and more options for more people. And it wouldn't be possible without our collaborating organizations. And if you do not see your logo or name on this list, please let us know, because we'd love to add you. Really, we'd love to add more collaborators, and we'll talk about that shortly. So we just shared a bunch with you about what First Place is. Most importantly, it's home for the people who live there. And it's going to be an amazing environment for people to learn and work there. And it'll be peace of mind for families and friends who come and go. And so that brings us to Links. Links, which we affectionately call our lifelong networking for communities of support, more easily known as Links, is all about creating confidence in the future, and to make sure that not only our loved ones have things in order and continue to learn, but that we do as parents and family members. And so this is our fifth in a collection of coaching groups. Next month, same time, same station, 10 o'clock, March 17, we will be focused on first responders. And it's not just about their responsibilities as first responders, it's about our responsibilities to make sure that we can bring this all together and that individuals are safe. So we've been a part of a lot of support groups after all these years. We're referring to ourselves as a coaching group. We're action-oriented. We want to help you take those next steps, and hopefully we are. We are grassroots, so this is a volunteer, parent-led organization and effort, and it's all about collaboration, because we know we all share the same sleepless nights. And we ask you this morning, are you ready? Are you ready to take those next steps with us? And we have brought copies with for you, if you haven't already completed one, of the action items that you can consider as you take those next steps. So legal, financial, health and wellness, and community building planning items. And we won't spend a lot of time on this, but it is for you to begin assessing yourself and realizing what you need to do, maybe what you have done, and what else is left to do. And it's all about getting ready and making sure you are. And so with that, we also introduced the supportive community, and we have been working as a committee to try to open doors to more options of where you go for those jobs and where you go for recreation and the conveniences. And we enlist your support also to add some more gold to this map of where we can go for those kinds of supports. You can see First Place just north of Thomas off of 3rd Street. And you see the blue, which is close to the light rail. We also have public transit on Thomas Road, which is that east-west corridor. And you can perhaps envision where your lawyer or your favorite pizza parlor is, or your barber or salon person is, and we're really looking to you to help us open more doors. So we have created also a letter, and we're hoping that you will take this with you and help us to let folks know that we want to make sure that we are good neighbors, that we want to support their businesses. We want them to know what autism is, what it isn't, to welcome us, to be great patrons, and to explore how we might work together as volunteers, as employees, or just as good patrons. And so help us open more doors. There are lots of spaces where we're looking to open those doors. I just mentioned the arts and culture organizations, where we're really taking off and very excited about that. We know from the families who have gone through the leasing process that they are interested in friends. And we make those friends because we have mutual interests and shared interests. So whether it's arts and culture organizations, whether it's an employment opportunity, you can see the kinds of spaces that we're working on. And we have a great collaboration with Gateway Community College, and it's now emerging with Phoenix College and the Maricopa Community College District, so that we do want to offer for individuals that lifelong learning. Our goal, 75 locations, and adding to the brand, which we love, which is a kinder Phoenix. And it's not just for the people with special needs, it's for all of us. And kindness doesn't cost anything, but we know how it makes us feel. And when we can educate and make and create a more aware community, we can create a kinder community. And Phoenix has really set the bar for what that means, as PBS NewsHour has acknowledged us as the most autism-friendly city in the world. And we want to make sure that we continue to earn that designation. And one of our most autism-friendly and most wonderful assets in this community has been a good friend of ours, Dr. Javier Cardenas. And I love telling the story about Dr. Cardenas because it warms my heart every time I do, and warms the hearts of families when I share that before he went to medical school, he was a special educator. And so he truly understands this and has had the passion for this for a very long time. And we're glad he went to medical school because he's now our son's neurologist. And he's the go-to person for us really on all things relating to Matt's care. And I'm thrilled that after years of talking with Dr. Cardenas and others at Barrow Neurological Institute and Dignity Health, that we are getting ready to launch a health and wellness program. And he is here this morning to share more with you. Thank you, Dr. Cardenas. You're right here, and you stand about right there.
Okay. All right. Hello to everyone in the room and, of course, online. Indeed, my name is Javier Cardenas. I'm the director of the Barrow Concussion and Brain Injury Center at Barrow Neurological Institute, which is just up the street. But we've had some discussions with some people from Tucson, so I've had some time in Tucson going to medical school and working with some of the programs there as well. So I want to talk to you about something that is very exciting to all of us, and that is looking at how we can address the issues associated with adults with autism, specifically their health, also being cognizant and very attentive to the issues raised with delivering that kind of care. It can be a very traumatic physical, emotional experience, and so we want to make sure that we do this in the best way. Unfortunately, we're going to be leveraging technology in order to do so. So here, in terms of a little bit of background for our program, this is Barrow Neurological Institute, which is just actually up the street from First Place. If you saw on that map and you drew a little line to the left, or less than a mile away. We're also off of the light rail. So when you do that tour, note that stop. And so we also have a reputation for neuroscience excellence, ranked in U.S. News and World Report for decades now. And for me, that actually represents something that is wonderful, specifically because of the neuroscience excellence. My institution has the resources to deliver excellent care, number one, but also the program and the institution is committed to the community. So it allows me and asks me, in fact, to do things like today and other meetings and collaborations and programs that really help us, our community, and the institution. I want to highlight a program that was created at our institution in order to really illustrate how these things can be done and how they can be successful. So the Barrow Concussion and Brain Injury Center was a program that was created in 2009 to address the issues associated with brain trauma. At the time, our military veterans were coming over from Iraq and Afghanistan with what was an epidemic of traumatic brain injury and concussion. The equipment and the protection that they had was now keeping them from dying, but because of that same equipment, they were suffering from concussions and brain injuries. At the same time, we were starting to see this more as an issue in our community, And there were problems with delivering this care. There would be people who were discharged from the ER or from the hospital that would come back into the ER, come back to the trauma center with complaints of headaches and thinking problems, just things that could not be addressed in an emergency setting. So we wanted to create a program that would address this in particular. And so what we did is we created the Barrow Concussion and Brain Injury Center, which was one of the first in the country. So this is our one of our first patients, who is a young lady who is a cheerleader who suffered an injury to her brain. And really what we wanted to see how we can break down the silos that were even within our own institution. And so while we boasted at the time of all these neuroscience specialties, neurology, neuropsychology, neuropsychiatry, all of the areas of excellence within the institution, they were really in many ways disconnected. And so what we wanted to do was to connect them. And we created a program in which we have a clinic that provides all of these services, and it started off quite modestly, a half day in a very small space in order to deliver this care. So now I'm happy to say that we have these specialties represented, and you may see some of them and be familiar with them, because these are, of course, wonderful people in our community. Myself, Dr. Kwasnika with Neurorehabilitation. The Brain Injury Alliance of Arizona provides a lot of the non-medical resources needed for our patients. So they literally borrow my office, and we bring them patients. We don't share any of the medical information, but they're able to provide a lot of the answers to those questions that are not about medicine, that may be about work, that may be about insurance, that may be about what they do, how they get around, and what are the practical issues around that. And then, of course, we have prevention. So while we are focused on the injury at hand, we don't want further injuries to occur. So we are looking at prevention of secondary injuries. We're lucky to have a social worker who can connect all of these dots, a neuropsychologist looking at the cognitive deficits associated with brain injury, as well as a psychiatrist to address the emotional changes. So the way that we see it is we address the physical, behavioral, and cognitive sequelae or consequences of brain injury in a single place, physically in a single place. So twice a week now, every one of these disciplines is together, which is a challenge, of course, herding those cats, bringing them in, but we've been able to do it. We've been successful at doing it. And we feel it is a very comprehensive model. And fortunately, our institution has replicated these multidisciplinary, interdisciplinary clinics throughout the institution, and so it's no longer an unusual thing. So then there are issues outside of the walls of our community, outside of the institution, that we also have to address. As you know, concussion is not just something that walks in and out of the doors of a clinic or an ER or a hospital. And so we have to deal with this at a sports venue. So what I'm illustrating here is we provide sideline coverage for ASU's women's soccer team, the football team, the ice hockey team, and the women's lacrosse team. And it is a challenge to do so when you have various vantage points that may be obstructed. And some of these, of course, may end up being even in bigger venues, such as the Super Bowl and the NFL. But what does that matter to our community? What does that matter to our youth? How do we address this same problem? Well, there simply aren't enough concussion specialists to go around to be at every high school football game, much less every high school competition, whether it be soccer, whether it be lacrosse, whether it be basketball. And so what we've done is we've created a tool that will allow us to virtually be anywhere. And this is the tool. It is called the Barrow Concussion Network that allows athletic trainers throughout the state to access concussion specialists. And what they do is they'll see something like what you see illustrated here. a concussion consultation. They'll submit the information that's relevant. They do the exams. They provide information about the condition, and then we will provide our information. Now, that can happen when they, and here's just an illustration of some of the cognitive testing, computerized cognitive testing that they can do. And we are provided, or we are notified via a text message that there's been a case, and then we can go into the case and respond to it. Now, the nice thing is this is a HIPAA compliant program, meaning it is medically secure in terms of privacy, and this consultation can happen on the sidelines, as you see illustrated here. It can happen in the locker room, it can happen in the athletic training room, or it can happen after the injury. So this is just a little bit of what can be done. Let me pick up there and make these. So to give you an idea of how this works, we focus and start our program with education, which is called Barrow Brain Mode. We provide baseline testing for our athletes using cognitive testing and balance testing. There will be a percentage of student athletes who sustain an injury, and then afterwards we're able to do post-injury testing. At any point along the way, we can provide that consultation remotely, safely, and free. So how does this apply to what we're talking about today? Well, first off, we know that we can't simply pick up a model, plop it onto another model, especially when we have individuals that we're trying to care for. So what Denise and I have been working on for many years is really how we start this process, how we use these same technologies and these same models to serve the adults with autism population. So of course at the center, always at the center, is the patient. These are patient-centered programs. And then we want to really identify those silos, those disciplines that need to be addressed. And from the medical perspective, we want to make sure that there is a pilot, and that pilot or that captain will likely be a primary care provider with other disciplines, and some of the disciplines that we've discussed include neurology, gastroenterology, psychiatry. These are things that we've looked at regarding high utilization, at least in the medical sense. Now, we know that there are other disciplines, other issues that need to be addressed, but we also know that we need to start somewhere. We also know that we want to make sure that we are including that non-medical aspect as well, like we do with brain injury, and that, of course, is where SARC comes in. So this is the concept for the interdisciplinary, multidisciplinary clinic. Fortunately, once again, my institution is very supportive of such a program, and we have the space, the physical space, to do something like this. Some of the other disciplines there. Now we really want this to be a true medical home, because it's not just that clinic that we want to make sure provides that care. This is going to be an institutional commitment, so that if there is an emergency where somebody needs to go to the emergency room, if there is a test, whether it's a blood test or a radiology test, that the individuals who touch that patient, who have interactions with this program, are sensitive and able to provide the same kind of care that we are delivering in the multidisciplinary clinic. So looking at it in terms of where we're going and how we want to start this program, we're looking initially at our first place potential residents, candidates who are interested, their families who want to participate. But it won't be limited to them, of course. The idea and hope is that this will be bigger than the physical places that we have, and that using technology we'll be able to expand beyond the walls that we have, and also draw from the community. But we want to make sure we get it right first. We want to make sure that we start small, that we deliver the excellence that we plan on doing so, that we work through any hiccups, any challenges before we make any promises beyond that. So in the short term, we want to make sure that we have all those elements. So we have those disciplines involved in our program, that we have the infrastructure, and this includes, of course, the technology infrastructure, that we are able to connect in the way that we hope, meaning that we have somebody at first place and we have somebody at our institution who has that connection, and then when we have the ability to replicate. So one of the key pieces of this program is that that there won't always be a need to come to the clinic or to come to the hospital. So that at first place there will be a health spot. There will be a location in which there can be electronic communication that, of course, is once again secure, that can provide some advice, information, potentially treatment, without having to come over, without having to come in. And that is where the big technology piece lies. That's where that big connection happens, to keep people out of the hospital. And I'm happy to say that with our practice and with concussion, the vast majority of those, 85% or more, have been kept from an ER, a clinic, or a hospital, which is great. So I think that's a good example. We also want to make sure that we have the capital for this particular aspect of the program, and that we really dedicate the resources to doing so. As you may have heard, we've started a collaborative group that extends beyond the walls of our two institutions, First Place and Barrow. That includes other community members, an advisory group that will help guide us in this program, so that we can make sure this isn't just a First Place and Barrow program, that this is an Arizona program, that this is something that can be replicated around the country. We have no problems with replication. In fact, we encourage it. Same is true for our concussion program. In our third phase, we want to make sure that we are connecting with our individuals, with our families, and making sure that we are taking the right steps, expanding, refining the program. Some of the things that we've talked about include baseline evaluations that happen in a healthy environment, specifically at First Place, where we bring people over and do initial wellness checkups, and then have that information uploaded into the program, so we have a nice comparison, making sure that there is a first connection right off the bat. Looking at how we have emergency action plans, where all the parties involved have a touch point, that all the parties involved know what are the steps we're going to take should there be an issue. That way we can prevent somebody from coming to the emergency department, but if they do, what are the steps we're going to take to make sure that isn't a traumatic event? And then also that involves all of our staff on our side. So we have to make sure that our providers are knowledgeable about these issues, and that they know how to interact with these patients. When we implement this program, the idea is to implement the two pieces together, both the clinic and the telemedicine piece. That way that there is that connection. And we also want to make sure that we've got all the right pieces to the puzzle. Initially, once again, starting with those high utilization areas, but also so that we have a roadmap for expansion and a roadmap for how we would grow appropriately. And then also looking at how not only can we contribute to the wellness and clinical aspects of these patients, but there's an opportunity for research. And that research may include the things like genetics, risks, etc. But moreover, research on how this process is working. how this will benefit people around the country. So to give you a little bit of an outline of how that may work ultimately is that we'll have a registration of the first place residents, those who want to participate, and that provides somewhat of a baseline for them. If there is an illness or an issue at the time, then ideally starting with a remote consultation so that we can provide that care quickly, efficiently, effectively, and avoid an inpatient experience. But should there be one, that we have the further care with the multidisciplinary clinic in the hospital or with any of the ancillary services that we need to provide. So with that, I'll turn it back over
to maybe stay for
sure.
a few minutes. I'm sure people have questions and they may come in online too.
Yes, I'm happy to answer questions about this program. Yes?
I'd like to understand from a telemedicine standpoint, where are we at now and our insurance actually operates? We do a lot of work. That's maybe my assessment so far. Obviously, it's a case where we have a cut and assessing whether or not it's impacted in the future as well. But when it was more general, review of it or not, or something like that, it can actually come out of the roadblock or so what needs to happen there in order for that piece of the puzzle to go well?
So the question for our audience who's watching has to do, I believe, with logistics and or insurance, right, in order to make these things work and removing some of the roadblocks for telemedicine care, correct?
Well, to me, it felt more that medically is what we were going to speak to me about, or a willingness to prescribe an antibiotic.
Okay. So a medical limitations of telemedicine, yeah. Right? All right. So the first part of that actually has to do with culture, right? So when you are looking at telemedicine and medicine culture, indeed there is tremendous resistance overall to the use of telemedicine, in part because, just like all of us, it represents change, and change is very difficult. And so there are those who are concerned, well, if I can't see it myself, if I can't touch, if I can't examine the patient, then that to me poses a challenge. And I'm going to want to have them come in. And that is a big cultural change and a cultural shift that is actually happening as we speak. There's in addressing that specifically has to do a lot with the generations of healthcare providers that we're seeing and the utility of it. A second part actually has to do with, indeed, insurance coverage. So, for example, there are some insurance plans in Arizona, specifically the access plans, who will pay for telemedicine services because, in part, they have to provide transportation otherwise, so that it's a cost savings. Now, the private payers, many of them currently don't do any telemedicine reimbursement. And so that is why you don't see it currently being widespread. And that telemedicine reimbursement tends to be significantly lower than an in-house visit. So in order to address those two things, at least if you look at the model that we've used for concussion, we've actually used a philanthropic model, meaning that when it comes to the care that we're providing and the care that we're helping out with for these athletes, we have a healthcare provider on the other side, so an athletic trainer. So in Arizona, athletic trainers are healthcare providers. They work under the direction of a medical doctor or a doctor of osteopathy, and so they are licensed to do so. So in that regard, there is a healthcare provider to healthcare provider connection. And indeed, that is a huge piece for liability, right? Because you've got a healthcare provider who's doing an examination on the other end. So the idea is that you're going to have a health care provider. We haven't decided what level that is, but whether it be a health aide, somebody who is on the other side of the screen, if you will, at first place. Okay, so that it will be somebody who has some type of a health background, so that for that provider to provider connection will be there, which is critical. And as opposed to a healthcare provider to the consumer or healthcare provider to the patient, which indeed can be challenging because you don't know what that exam may look like. The other aspect of things is that when it comes to that reimbursement, as I mentioned, we use a philanthropic model to provide this service using foundation dollars. And that's something that we are looking at for this program as well. Is it integrated into that aspect of things, or is it part of a payment model? And there are opportunities. The nice thing is that the current model that we have is a software-based telemedicine model. What that means is you can use your smartphone, you can use a standard computer. You don't have to buy heavy equipment that may create a cost-prohibitive situation. So. In short, we are addressing those particular issues. There are some people that are going to be more comfortable with that aspect, and naturally, we're going to use those individuals who are more comfortable with the telemedicine ecosystem. Now, one of the other things that I neglected to mention is that when it comes to that telemedicine communication, it is likely to go to that captain, to the PCP captain. And that PCP captain can reach out to those other disciplines depending on what it may be. So let's say it is a cut on the finger that may or may not need antibiotics. Once again, communication with the healthcare person is that first step. But let's say it's something like a neurological issue, a seizure, or a gastroenterological issue. Then that PCP will reach out to the other members of the team and have them communicate directly with the person who's at first place. So that's how we foresee this. We know it's not going to be perfect. We know that there are going to be challenges, and so we will do our best to address them as they come. But I think that's how, based on our experience thus far, we feel that we can address some of them.
Well, thinking about the question. As your whole baseline, probably will be careful problem that you're not going to have to present like something. I don't find that you know something that you have to question time. But if you have the baseline on the person and you know what their history is, so it's something you don't know outside your space.
Absolutely. No, that's critical. Is having that first touch point. Many times for us in our clinic model, what we've looked at is having that initial visit be a hands-on visit, and then subsequent ones can be a telemedicine visit, because indeed you have that experience, you have that interaction, you know the individual, and you can say, oh yeah, they have a history of repeated sinus infections. Yep, easy for us to address. Yes. I saw something pop up on here. Was that a question that was popping? Oh, okay, good.
Yes. So we've been hearing about electronic medical records for a long time, and I would love to think that we don't have to fill out another one of those forms because it would all get loaded. And I had to fill one out a few weeks ago, even that included his diagnosis after 20 some odd years. What would you suggest to us as families in terms of where do we go to start that process of getting all those electronic medical records, or all the medical records loaded, so that you would have them?
Yeah. So it creates a huge challenge, and I don't think. So the question, I'm sorry, for the people on the line was, where do we go to start the process with electronic medical records? They are the bane of families' existence. They are actually the bane of our existence as well for many reasons, including that one, but also many more. But what I would say is that there are some processes that are challenging because until the individual is scheduled for an appointment, many institutions will not have that stuff uploaded. That's challenge one. Challenge two is, as you probably experienced, when you call to request your medical records be sent, that doesn't always happen. It also tends to be from multiple institutions. And one of the things that is true of just about any institution is that the records, while they are your records, are also the property of that particular institution who's using that electronic medical record. And so the flow of information is inhibited many ways by the legal and proprietary issues associated with that. So what I would suggest is indeed to start gathering that information in terms of those medical records, especially the information that is most pertinent. So, for example, those the sheet that has diagnostic codes on it, meaning these are the diagnoses that my son or daughter has. Imaging that is relevant to their condition. So whether it's they have a seizure disorder and they've got an MRI of the brain, or they've got an EEG, if they have something going on with their gastrointestinal system, what some relevant studies have shown in the past, if they have been hospitalized for something serious and what that outcome. So usually that it would be the discharge summary, right? So those are kind of the relevant things. And I know it's hard because you ask for records and you're going to get like every single day they were in the hospital, including, you know, what their heart rate and blood pressure was, whether or not they went to the bathroom, what their urine. So that stuff obviously is less relevant, but you wouldn't necessarily know that. So some of the key things, once again, are summaries, discharge summaries, especially some of the imaging or testing that is relevant, whether it's be relevant because it has a positive finding, or relevant because they were looking for something and it was negative, as well as some of those imaging. Thank you. Other questions? Yes.
The PCP, are there certain PCPs you're envisioning working with this program, or is it the PCP that our son or daughter has now?
So the question was, are we looking for a specific PCP, or is it the PCP that is currently providing the care for your son or daughter? So we're actually looking for a PCP that is within the institution. So a captain of the ship, once again, who is centralized. Now, the person that we're looking for to identify, at least in the past, we had identified somebody who had experience with autism, obviously somebody who actually had some credentialing in alternative medicine and therapies, as well as a broader understanding of autism and the health-related aspects associated with it. So that is actually what we're looking to do. One day in the future, at least on the remote aspect piece, the telemedicine type piece, we hope that there will be multiple PCPs involved throughout the community. But for this program, in order to be straight with you, we are actually looking to have it more centralized at our institution.
Then the follow-up, I guess, you may not know it, but maybe somebody knows. Does Access allow you to change your PCP? Because they just assigned this one.
No, you didn't change it. I had to. My daughter.
But then you have certain networks too, right? So you're not going to choose a PCP within whatever.
I went to I went to somebody near me. I went to the first one. I used my PCP, but it would take. Yeah, you have to.
So the follow-up
would be an Access PCP.
So the follow-up question was, with Access, can you change PCPs? And the short answer is yes. Our institution is an access provider, and by that we actually provide service and care to those who are in multiple access plans. Now, insurance, of course, is a challenging thing, so that would be something that we would look at. Is that plan currently provided? If so, obviously, then that should be pretty easy. If not, what are the processes? Do you and your son or daughter want to stay on the existing plan and stay with your PCP, which is perfectly fine. By no means is this program a prerequisite for living in first place. And then if you are willing to change, how can we help in that process? Other questions? So the question is, when I mentioned that we work on a philanthropic model for our current telemedicine program with our community concussion service to athletic trainers, that is 100% free. We actually don't bill insurance. We don't submit those into a program or for reimbursement at all. It is a community service that we provide. And the foundation, our foundation, provides us with the funding for the technology, the time, and the support services to provide it. So that is indeed a goal, is that we would be able to, at least that aspect of the program is covered. Now, there are also other models. So, for example, we have a traumatic brain injury and domestic violence program where we partner with shelters to provide care for those who suffered brain injuries as a result of domestic violence. Many of them are insured with access. However, as you know, access doesn't cover a lot of things. And so our philanthropic model for that is to supplement their insurance and provide funding for whatever access doesn't cover in that particular individual. And so there are models that various models that we can use that include philanthropy to supplement those aspects of things.
Yes. I know there are a lot of needs in the community, and one of them that we always come up short on in terms of answers is behavioral health and people who are in crisis situations. Do you see this program getting to that point where we could offer some type of inpatient space to help somebody adjust, whether it's their meds or other issues and concerns? Do you see where we're starting is something that could grow to accommodate that, or are you aware of other programs or opportunities locally or nationally that we could help refer families to who are in need in crisis?
So the question is, in the event of a psychiatric or behavioral crisis, what are the resources available now, and then what might they be in the future, especially in the context of this program? So what I can tell you is that part of our multidisciplinary program for brain injury right now includes a neuropsychiatrist. She was the last medical piece that we added to our program and has been a godsend. As you can imagine, when it comes to a head injury, actually your brain is responsible for your emotions. And so when it is injured, then your emotions can also change, and sometimes in very severe ways. What I would hope is that indeed for our model that we have someone similar, if not her, then someone who would also be able to provide that care and the multidisciplinary model. As it stands now, St. Joseph's Barrow does not have an inpatient psychiatric unit, and I don't foresee us being able to utilize anything like that at our institution unless there was a larger reason and or program that was going to do so. That said, we do work with some of the crisis centers locally. We actually have crises unfortunately on a regular basis, and so we have really a protocol to address that. And in fact, had one last week. And so we have a protocol to do that, and not unlike with autism, for those who've suffered a brain injury, especially for those who suffered a severe brain injury, it is a population that is not a typical population. And so really having that sensitivities and that collaboration with those institutions is important. And in fact, just as an aside, there was an issue in which we had to call security, and the initial security officer was the wrong person for that situation because he did not understand brain injury and actually escalated the issue. Fortunately, his partner had some experience with people with a brain injury and was able to help tremendously. And in fact, the patient said that he trusted him. And so that is really what we're looking for when we have those relationships and we have those protocols and we have those institutions that we can properly collaborate and trust. And so while there are a few crisis centers in the Valley, there's a smaller number that we work with because we know they take care of our patients the way that we want them to take care of them. Other questions? Yes.
How do you see this generalizing to individuals, or especially individuals who aren't necessarily living near a hotspot?
So the question is, how do we see this generalizing beyond, once again, beyond the walls of these two institutions? So what our hope is that we start with a relatively small model, even with a half day a week, which is what we had started with previously with our other programs. Really get that model going. And then once that expands, and once that, at least within the first place population, we're comfortable with the work that we're doing, then we would actually open it up to anybody who would be interested to be part of that multidisciplinary patient program, regardless of where they're at. And so, it may happen in a matter of months. It may happen, in a year. Don't know. But it's we have experience with that already, and it's something that I think we can do well. And then once again, I think the bigger question is replication of something like this in other markets, in other cities, in other states, and hopefully we'll be able to do that as well.
You see it taking over the challenge of medication.
So the question was taking over the challenge of medication.
One of my fears for my son is down the road, where we will have patients running out, or maybe he won't have insurance and I won't be here to help, and we won't get covered, or just the whole, what if some glitch occurred and you can't times where you have to fight through the whole system to be sure that prescription is paid for you at CVS.
Sure.
And he can't fight that out. So, if we have a multidisciplinary system, and there is somebody to help to see that covered as well.
So the question was, do we see this program addressing issues, including of people missing medication and not having them? What I can tell you is that when it comes to electronic medical records, one of the few things that's very positive out of electronic medical records is actually a reduction in medication prescription errors. It's been significantly reduced, in part because our handwriting is terrible, but also a lot of the referrals or the refills are now automated, meaning that I'll see a pop-up from a patient saying, hey, this is going to be finished soon. Can you renew it electronically? And then, of course, there are other redundant components, including a fax that comes, including usually a call that comes to our medical assistant. In short, I don't see it solving the problem, but it may reduce that issue tremendously. one thing that I didn't show, and I don't know if it's on here, is the medical memory video. If you don't have it, that's okay. All right. So let me tell you what medical memory is. So medical memory is actually it is a proprietary tool that is essentially a tablet that has a HIPAA-compliant program for recording a visit. Now, the context that we currently use this in, especially for our brain injury patients, because their memory is terrible because they've suffered a brain injury, and even in the mildest form, they're not retaining information, concussion, etc. And so what we do is we record the assessment and the plan. And the way that this works is when the patient comes in for the first time, they sign into this program. It includes their email address, and they create their own password. And then what happens is they are invited to it. Now, once again, this is a HIPAA-compliant program. And so what we do is I will record, and people, they have different comfort levels as to what they record. Some people will record the exam, all kinds of stuff, but we'll record those pieces. I will record imaging results and show them with the patient in the room. Okay. Now, after that's done, I hit stop, and then they get an email, and in there is a link. This is what I said. This is what we talked about. And actually, for our side, it's great because it's cut down on a lot of the questions. And on the patient side, oh, I forgot, what did he say about this? And he droned on about that and this. Now I can go back and I can watch it. Okay. So is it on there?
Yeah, so we're going to do
okay. We'll do a quick swap.
A quick swap.
Okay.
Of where we're going to show. We have 2 brief segments, and I'll explain this. So these are 2 brief segments from a medical memory. And so here is our son in a visit with Dr. Cardenas, and I'm there, but pretend I wasn't there. And within minutes of the appointment being concluded, I get something on my email that says your medical memory has now been uploaded. And so I'm just going to press play, and so you can see a little bit about what's going on, and you'll hear Dr. Cardenas' voice also. So just for the people who have tuned in, and we apologize for our technical difficulties, this is actually a second medical memory. So Dr. Cardenas, if you wouldn't mind indulging us to now describe what's happening here. And as I mentioned, I am in the room, but I'm pretending I'm not in the room. And for those of you, you can see Matt will be more interested in making faces in the camera than he is in anything our dear doctor has to say. So you want to describe what's happening now?
Sure. So in this visit, we're summarizing what we've talked about. So what's gone on, what Matt's issues and his concerns are, and or his caregiver. So sometimes there will be a representative or somebody who helps out from the institution, etc. What those concerns may be, and then the things that we're going to be doing or recommending format.
And as was described again during our technical difficulties, if I had a question and I wasn't in the room, I could be communicating also things that, again, our son might not be asking and that I would want to ask for Matt's care. Dr. Cardenas also acknowledged that I could share this with other family members, and I have, so that, when asked about how Matt's doing, they don't have to just hear it from me, but they could actually see through this medical memory what it's all about. And then these medical memories actually collect in my inbox, and I can call all 5 or 10 of them up at any time.
Okay, Matt, so I want to show you and your family the weight change over time. What we can see is that an early weight in 2012 of 103 pounds, but then you're able to gain weight all the way up to 121 pounds in 2014, but then we're back down to 105 pounds with today's visit. So Matt, we just went over your change in weight, and we also discussed things like seizures and medications. So we want to make sure that we help you the best way that we can to gain weight, to not have seizures, and to reduce side effects from the medication. So what we're going to do is we're going to have you see a dietitian, a specialist for weight. We're going to reduce one of your medications, the zonisamide. We are going to have you see that seizure specialist, the epilepsy specialist. And then we're going to have you back in just a couple months. All right? And we will update on all of those things, and we'll make sure that your medications are renewed. Sound good? Okay. Thank you.
Great. Well, thank you so very
Thank you.
much for joining us.
Appreciate it. Thank you.
And hopefully you could feel and understand now our excitement about the program that's happening in collaboration with Dr. Cardenas and First Place and the broader community. Over the past many months, thanks to the generosity of Vitalist, we've had a facilitator bringing our agencies together, including private healthcare insurance companies, Access, other area agencies, including SARC and First Place. So really looking more broadly, not just where we're starting, but where this goes, and to make sure that it can go far. And then in the PowerPoint that's posted, you'll also find our upcoming links meetings. The one that is not listed is next weekend's tour at a First Place. So if you haven't been there and you're interested, or if you've been there and you're interested in going back, please join us. If not for the tour, for some bowling, because I know a few of you are working on it. So thank you so much for joining us. Remember to go online and get some of the information. We'll post those medical memories too. And have a great weekend. Thanks.